Assalamu alaikum. Good morning, everyone. My name is Dr. Mohammad Zubair, and my moderator for today's lecture is Dr. Pradeep Kumar. My today's lecture is on treatment of locally advanced and metastatic renal cell carcinomas. So let's begin. Locally advanced renal cell carcinomas. This is the fifth lecture of already ongoing series on renal cell carcinomas. Previously, we described the introduction and diagnostic investigation and management of nephron sparing and radical nephrectomies already explained in detail in the previous lectures. So we will be discussing on the surgical management of locally advanced renal cell carcinomas. So locally advanced renal cell carcinomas are there is no definite principles in how to manage these things, but it is still an ongoing debate and it is very much debatable. So the learning objectives of today's lectures are adrenalectomy in renal cell carcinomas, lymph node dissection, inferior vena cava involvement, and local recurrence after radical or nephron sparing surgeries. So adrenalectomy in renal cell carcinomas. Overall incidence of adrenal metastasis is less than 5%. Multivariable analysis showed that upper pole location was not predictive of adrenal involvement. Radiographic and intra-op findings should be the guiding tool. Only 48 of the 2,000 patients underwent concurrent ipsilateral adrenalectomy, of which 42 of the 48 interventions were for benign lesion. So just 8 cases came out to be adrenal gland positive in that case series. Clinical indicators for adrenal involvement to guide the surgical practice, these are not the guidelines, but just to guide the surgical practice are the diffuse involvement of gland by the tumor, large tumor size greater than 10 centimeters, extrarenal tumor involvement, tumor thrombus, renal lymph adenopathy, renal metastasis, and adrenal mass on imaging. So on imaging from radiographic point of view, if there is suspicious of adrenal mass along with the renal mass or the upper pole lesion that is abutting or something going inside you in the adrenal gland, so in that case adrenalectomy should be performed, or in thorough finding if the facial glands are not intact, then adrenal gland should be taken out, otherwise there's no such indication for adrenalectomy. So these are the EUA guidelines on renal mass 2021. The summary of evidence is ipsilateral adrenalectomy during radical or partial nephrectomy has no survival advantage in the absence of clinically evident adrenal involvement. And the recommendations are to do not perform ipsilateral adrenalectomy if there is no clinical evidence of invasion of the adrenal gland. This is a strong strength rating. And American guidelines are no different for patients who are undergoing surgical excision of a renal mass. Physicians should perform adrenalectomy if imaging or intra-op findings suggest metastasis or direct invasion of the renal gland. Moving on for the lymph node dissection.
There was an era when people used to say it is mandatory to remove adrenal, especially for a radical nephrectomy. And radical nephrectomy, when Robson want to take, okay, we want to do a radical nephrectomy, and usually the term radical nephrectomy in old time was used when there is no nodes, when there is no extension into vein or vena cava, and it is a purely localized disease. So we used to say it's a localized disease, and we want to do radical nephrectomy. And in radical nephrectomy, it was mandatory, especially for middle and upper pole, to remove adrenal necrosis. But now, as your literature shows, out of 2,000 cases, only 6 patients has something there that is 0.1, 0.01 or 0.02% chances. So because there is a lot of operative and post-operative complications are associated with the adrenalectomy. So people used to say once there is no clinical evidence of the involvement of the adrenal on the CT or your imaging technique doesn't show anything in the adrenal, you are dealing with a lower pole or a small tumor, so there is no need to go into the difficulty. Once you have a lot of nodes there, when there is extension into the vena cava, then the concept of radical nephrectomy is gone. that area is basically a cytoreductive.
Right.
In vena cava involvement or a vein involvement or a lymph node involvement, lymph node not subcentimeter, sizable lymph nodes. So in that time, either you go and remove adrenal or you left adrenal, it doesn't matter. So end of the day, this is the expertise and the relaxation attitude of the surgeon. If he or she felt they are able to remove easily, smoothly, without any complication, go ahead and remove. Otherwise, there is no need of any heroic act at that time because, as you mentioned in the guidelines, there is no added value.
Lymph node dissection. The presence of lymph node metastasis is an important prognostic factor and defines the high-risk subset of patients with advanced renal cell carcinomas. Although lymphadenectomy for RCC provides accurate staging, the therapeutic benefits of routine lymphadenectomy are controversial. Even in patients with radiographic adenopathy, only 30 to 43% of clinically enlarged lymph nodes contain metastatic disease. And another study showed that less than 20% of clinically suspected metastatic nodes are positive on histopathological examination. Coming to EUA guidelines on renal mass, the recommendations for lymphadenectomy are: do not offer an extended lymph node dissection to patients with organ-confined disease, and in patients with clinically enlarged lymph nodes, perform lymph node dissection for staging, prognosis, and follow-up implications. The strength ratings are weak for both the recommendations. American guidelines says for patients who are undergoing surgical excision of a renal mass with clinically concerning lymph node or regional lymphadenopathy, physician should perform a lymph node dissection for staging purpose. So both the guidelines are pretty much same. It is based on the judgment, clinical judgment of the surgeon to do the lymphadenectomy, how extensive lymphadenectomy should be. Patients with two or more of the study conducted by Blue et al. Showed suggested a patient with two or more of the following pathological risk features were found to have increased risk for lymph node metastasis greater than 40%. These include the primary tumor of greater than 10 centimeter, clinical stage T3 and T4, high-grade tumors, sarcomatoid features, and necrosis on histopathology. So this is a table form which shows that when the number of risk factors increase from 2, 3, 4, or 5 onwards, the percentage with positive lymph nodes in retrospective series increases from 4.4 up to 53 if these pathological risk features were positive. If all 5 were positive, the positivity is 53%. And in other series, the positivity increased from 30% and going up to the 50% as well. And this is another study which shows the frequency of lymph node positivity detected at extended lymphadenectomy in patients with lymph node positive renal cancers and at radical nephrectomy. When you're doing the right side radical nephrectomy, the pre-caval nodes and aortocaval nodes positivity ratio is 20%. And on the left side, the pre-caval lymph nodes are 7%. So this is just to give the idea how surgeons should move forward with the lymphadenectomy.
But these are the extended lymphadenectomy terminologies are Christian, agree have doing it holding. Another way to go from one side to another side. So they clearly do if the tumor is on the right side, they start doing radical lymphodissection from the right side. You are agree with this terminology, you want to do like this, or is there any role or there is no role of agriculture is not supporting regarding the lymphodissection. There is only 1 or 2 or 3 this type of heroic study. The primary principle is to remove the primary area to a radical one. If there are ipsilateral sizable nodes that are easily manageable, remove that. If they are not sizable, not easily manageable, we can left them. The only indication of lymphadenectomy is for a staging purpose.
Right.
This is the limitation of Robson classification. Robson classification mostly based on size. It did not say anything about perinephric strandings or often before you need proper staging to want to do lymphadenectomy. Again, it is not an essential part. But if it is safe, it is sizable, large node, and you know you are able to shape it off from the vena cava or from the aorta between the two major vessels. Go and do that. But if you already do more than 9 or 10 or 7 prints of that, patient already being shocked, your towel area is full with the blood soaked gauze, don't need to do any heroic work. Because if an RCT 10 centimeter plus along with total involvement, the, the outcome is the same either you remove node or you you left the room. It all depends upon the clinical scenario as well as the benefits involved. There is no additional benefit. Similarly, this extended lymphadenectomy, no additional benefit. There is no benefit.
Can we have Nadesh? Nadesh,
जी सर
do you want to add something in lymph node addiction and RCC?
Sir, regarding the guidelines, according to the guidelines of the EUA, if there is the clinically positive or the clinically positive on the CT scan, it is positive, then you will go for the lymphadenectomy is recommended, as per he also mentioned it. But I'm also seeing this thing that the external lymphadenopathy adenectomy is recommended or not. I'm not sure about it. I don't think so कि इसमें इतना कोई रोल होता है इसमें.
Should only be done when there is evidence of lymph nodes. Then we can go for lymphadenectomy and lymphadenectomy. We don't do it.
The European Organization for Research and Treatment of Cancer randomized trial of lymphadenectomy at radical nephrectomy failed to show a survival advantage for most patients undergoing lymphadenectomy. A large series from Mayo Clinic of nearly 1,800 patients failed to show a therapeutic benefit to lymphadenectomy in patients with non-metastatic RCC. However, a large European study of 1983 patients suggested better cancer-specific survival in patients with large, bulky tumors and sarcomatoid features when a more extensive lymph node dissection was performed. So, therefore, lymphadenectomy may be performed in patients with clinically suspicious lymphadenopathy for staging purpose, and lymphadenectomy should not be performed routinely in patients with localized disease and clinically negative nodes.
There is no survival advantage related to taking out lymph nodes. Unless there is a visible single lymph node at the hilum, you can take that out to remove the disease which is visibly there. Unless that is the solution, you do not take out it.
Inferior vena cava involvement in RCC patients. One of the unique features of RCC is its intraluminal growth into the renal venous circulation, also known as tumor thrombus. 45 to 70% of patients with RCC and IVC thrombus can be cured with an aggressive surgical approach, including radical nephrectomy and IVC thrombectomy. Involvement of venous system with RCC occurs in 4 to 10% of the patients. Tumor thrombus is differentiated from the bland thrombus by filling defects, enhancement, and vessel lumen expansion and continuity with the renal mass. So filling defect enhancement is very much important factors in this. You perform CT contrast, and on post-contrast study, there is enhancement on the scan. Then it should be considered as the thrombus is not a bland thrombus but a tumor thrombus. So CT demonstrate right lower pole mass, and the long arrow shows the tumor thrombi extended. It is the level 3 thrombi which is extended below the diaphragm, and these are the collateral vessels which are due to the tumor thrombus. A microscopic invasion of the wall of IVC is also a strong predictor of cancer-specific survival. So, MRI with gadolinium and micrography are the study of choice. Recent literature suggests multiplanar CT is equally informative. Renal artery embolization is not essential, nor recommended for the routine management of IVC thrombus. So this is staging of IV thrombus. Level 0 is limited to renal vein. Level 1 is extended into IVC but less than 2 centimeter extended. Level 2 is extending to IVC greater than 2 centimeter from renal vein but below hepatic vein. And show you on this slide. This is level 0 that is confined to renal vein, and on level 1 it is up to less than 2 centimeter from renal vein. It is extended to IVC, and this is greater than 2 but below the diaphragm and below the hepatic vessels. This is below level 3 is below diaphragm but above hepatic veins, and this is above the diaphragmatic level up to the right atrium. So pre-op consideration in management of tumor thrombi. Low molecular weight heparin has a potential benefit of reduced risk of pulmonary embolism, tumor and blunt thrombus shrinkage, and prevention. Role of IVC filters, green film filters is still uncertain. Pre-op embolization was associated with increased operating time, blood loss, hospital stay, peri-op mortality in patient with disease. Use of pre-op transesophageal echo is recommended. Consult a vascular surgeon for level 1 and 2 thrombi if necessary. For level 3 and 4 thrombi, cardiothoracic surgeon consultation is essential. It should be taken on board before going into surgery. Surgical method selection depends upon the level of thrombus and the grade of IVC. So how to manage the level 0 and level 1 tumor thrombi? IVC thrombus managed with the Satinsky clamp to achieve vascular isolation, and it is partially occlusive, non-adherent, do not require extensive IVC dissection. And in this, the important factor is to avoid excessive renal vein manipulation so that your thromboembolic event should be avoided. And this could be done via a flank incision. More extended incision does not require much. And on the level 2, the incidence is 3%. IVC thrombus managed by sequential clamping. This is very important. Sequential clamping of lower IVC first, then contralateral renal vein, and then cephalite IVC. Along with mobilization of IVC and occlusion of lumbar veins, allowing for vascular isolation. So after you remove the tumor thrombi and perform the radical nephrectomy, the declamping is should be following in the same order. Lower IVC should be reclaimed first, and before closing the repairing the renal lower IVC or IVC, you should allow a few 5 to 10 ml of blood to in your field to avoid any air embolism when you declamp the upper IVC clamp.
Can you add something regarding sequential clamping? How it is done and what are the precautions that we usually take? And level 2 थ्रोम्बस में जो करते हैं थ्रोम्बेक्टमी करते हैं इसमें हमारी प्रिपरेशन कैसी होगी, हाउ डू यू स्टार्ट, कितना करोगे वो
सर एज पर ही मेंशन लाइक कि सीक्वेंशियल आपने क्लैंपिंग करनी होती है, हम वैसे सीक्वेंशियल क्लैंपिंग इस तरह से करेंगे, लेकिन सीक्वेंशियल क्लैंपिंग के बाद आपने ना मिल्किंग करनी होती है टू द ऑफ द थ्रोम्बस की जो साइड होती है ताकि वो वहां से टुवर्ड्स द रीनल वेन की तरफ आ जाए, और फिर उसके बाद जाके आपने उसको मतलब उसको पूरा प्रोपेल करना होता है। प्रोपेल के बाद जो है आफ्टर जब आप फ्रॉम लोअर टू अप जो है आप बंद कर रहे होते हैं, मतलब जब दोबारा से आप उसको रिपेयर कर रहे होते हैं तो उसका 5 to 10 ml जो है आपने उसको ब्लड को प्रोपेल करने देना होता है ताकि जो रिमेनिंग थ्रोम्बस है और वगैरह अगर इस तरह का कोई है तो वो भी निकल जाए साथ में। एंड देन आफ्टर जो डीक्लैंपिंग है वो भी आप सेम मैनर में करेंगे कि कॉन्ट्रालेटरल पहले करेंगे, सॉरी इंफ्रा करेंगे, कॉन्ट्रालेटरल एंड देन सुप्रा करेंगे, उसमें सेम चीज होगी। जी सर,
you do with this blank approach or
ट्रांसपेरेंट सर हम तो रिट्रो कर रहे होते हैं सर, ट्रांसपेरेंट तो वैसे रिकमेंडेड होती है लेकिन हम लोग रिट्रो कर रहे होते हैं।
लेवल 0 and 1 में करते हैं, लेवल 2 और 3 में जो है ट्रांसपेरेंट
ये तो जो है वो रेट्रो रेट्रोनली हो नहीं सकता, लेकिन दूसरी तरफ की आयकर 0 और 1 तो हो जाए 0 1 हो जाएगा, ये इसकी बात
जी।
लेकिन this is a very aggressive approach. हमने कितनी बार कॉन्ट्रालेटरल वेन को डिस्टर्ब किया है, तब हमारा तो क्या एक्सपीरियंस है सर, आप बताइए। नहीं किया तो इट्स देखें, अगर आप वेन को क्लैम्प करें और आरटी उसकी पेटेंट है तो फिर तो वैसे ही हो जाएगा, किडनी बिल्कुल कपूर हो जाएगा। इट्स अ वी यूज्ड टू टेक ऑन लूप बट वी नेवर अप्लाई, at least in my practice आप नहीं कर सकते। It's all depend if thrombus is a fixed thrombus or a mobile thrombus. In case of a fixed thrombus, instead of all those things I want, if I am on the table, I will call a vascular surgeon to do and do what the vascular surgeon wants. But a mobile thrombus that can easily be on the contrast CT or in a good ultrasound after accidents to hold off on either side of the metacarpum for a while or a sponge forceps press, release the tendency so that the gas of blood come out at the same time, the whole thrombus used to come out. But by clamping or contralateral vein, I never do like that, and I haven't seen like that by all of my seniors here or anywhere.
So I can help you with the reason for clamping or taking it on sting and blocking it is that the flow of the blood that is going towards the heart from the contralateral kidney, this flow can drive the thrombus to the heart and into the pulmonary system with that flow. That is why you block the flow, and with the flow you cannot open up the IVC and take out the thrombus. Now here in this picture you have shown right kidney. So clamping the left kidney is not a big deal because it can be drained by adrenal vein and parietal vein. But if it's a left-sided kidney, then it becomes an issue how to block the venous drainage of the right kidney. Then if it is inadequate or only the renal vein is draining the right kidney, then you have to provide a bypass drainage to the kidney and then clamp it. And if you don't clamp it, then there is chances of embolization. Theoretically, I also haven't seen anyone doing it. Theoretically, so that's how it should be done. That's how it should be done. That's how it should be done.
अगर हम तो नहीं करते, मैंने भी नहीं देखा, आपने देखा कि आप बहुत clamping of contralateral vein नहीं है, अगर बुकिश तो है ये
again जो हम अपनी टीम है, जो हमारी एग्जाम के लिए तैयार हुई है, you should know what is present in the book and you should know the thing it is mentioned in the book, but in my experience and in the experience of my seniors in my department, it hasn't been that. So go for the practical thing as well as the bookish one in any area of controversy. अगर सिर्फ आप अपनी प्रैक्टिस बताएंगे तो भी जरूरत है, आपको बुक का पता होना चाहिए और बुक को बताने के बाद ही आप उसकी क्वारीज बता सकते हैं कि इस तरीके से बिल्कुल निकाल में दूसरे के को बाईपास किया नहीं है, प्रॉब्लम हो सकता है, प्रॉब्लम बन सकता है। तो आई हैवंट सीन दैट थिंग इन माय डिपार्टमेंट एंड माय लाइफ। यदि आप
बुक का रेफरेंस है वो तो अच्छा
है, ये तो लिखा है, एमए में लिखा है।
So, management of level 3 and level 4 thrombus. These are managed by mobilization of liver, providing exposure to intrahepatic IVC, rejection of the thrombus to facilitate placement of upper IVC clamp just below the level of hepatic veins. And Pringle's maneuver should be performed with suprahepatic clamping to temporarily occlude the hepatic blood flow. If we are to clamp the hepatic blood flow, suprahepatic veins are above the hepatic veins. If we are going to apply the clamp, then Pringle's maneuver should be performed to block the porta hepatis and hepatic blood flow. for not more than 20 minutes. And for Fogarty balloon or Foley's catheter can be used for thrombus removal. So we apply the clamp on porta hepatis, which is from where the blood supply to the liver usually done. तो जब हम पोर्टा हेपेटिस को क्लैम्प करते हैं और एक क्लैम्प हमने ऑलरेडी सुप्रा हेपेटिक जो है अप्लाई किया हुआ है आईवीसी में, तो जो वीनस फ्लो है लिवर से वो कॉम्प्रोमाइज्ड है, तो उससे अगर हम वो क्लैम्प ना करेंगे तो जो है हेपेटिक इंजरी हो सकती है, तो उसको जो है वो
वीनस इंगॉर्जमेंट की वजह से जो है वो हेपेटिक इंजरी हो सकती है। इसमें दो बातें बहुत इंपॉर्टेंट जो आपको बतानी जरूरी है एग्जाम में लिख बैठे। ये लेवल 3 के अंदर आपने जीआई सर्जरी टीम को इन्वॉल्व करना है, हेपेटिक इन्वॉल्वमेंट आपने नहीं करनी। अगर आप एग्जाम में बताएंगे कि लेवल 3 थ्रोम्बस आप निकालने जा रहे हैं तो आप कहते हैं आपने जीआई सर्जरी टीम को इन्वॉल्व करना है। फिर दूसरी इंपॉर्टेंट बात इसमें ये है कि अगर लेवल 3 थ्रोम्बस व्हिच इज इन्वॉल्विंग हेपेटिक वेन और यू हैव टू क्लैम्प, it is not involving hepatic veins but you have to clamp the suprahepatic veins, तो फिर अब आपको ना venous bypass करना पड़ेगा, ठीक है ना, क्योंकि अगर hepatic circulation आप ब्लॉक कर रहे हैं तो पेशेंट शॉक में जाएगा, तो
हाइपरटेंशन
ये करने से पहले आपको venous bypass करना है। ये बहुत इंपॉर्टेंट चीज है लेवल 3 थ्रोम्बस के लिए, तो ये बतानी जरूरी है इसमें।
अब नेक्स्ट में एक चीज और भी है कि जैसे आप फ्री ऑफ असेसमेंट कर रहे होते हैं तो यह ना प्रोसीजर आपके फ्रैंक इंसिजन से या लेटरल पोजीशन पे, इसमें आपने यूनिलेटरल और बायलेटरल शेवरॉन पड़ेगा, तो शायद मर्सिडीज में।
सर नेक्स्ट स्लाइड में
ये बात ये है कि जैसे हमारे सर्जन साहब ने फरमाया कि आपको वीनस बाईपास भी करना पड़ेगा, तो ये वीनस बाईपास आजकल लिवर ट्रांसप्लांट का दौर है और ये बहुत ज्यादा किया जा रहा है, और इसकी टेक्निक का नाम है, काफी कॉमन नाम है, बहुत अरसे से चली आ रही है, और उस टेक्निक के बाद से ही लिवर ट्रांसप्लांट कामयाबी की तरफ किया। वो टेक्निक नाम पता है किसी को? स्टारजल्स टेक्निक। स्टारजल्स में इनिशियली तो पोर्टोफिमोरो जुगुलर बाईपास करते हैं, अब शायद सिर्फ फिमोरो जुगुलर बाईपास करते थे, वहां से कैलकुलेट करते हैं, मशीन में जाता है रिंग में, फिर यहाँ से एक्सटर्नल जुगुलर में आप उसको तो इस तरीके से जब आप क्लैम्प करते हैं मैंने कहता हूँ तो वीनस रिटर्न पे और वाइटल ऑर्गन्स पे इतना ज्यादा प्रेशर जो है वो नहीं पड़ता, उसके डैमेज के चांसेस कम होते हैं। और ये काम सर हम अपने एनिमल थिएटर में हमने बड़े अरसे तक डॉग्स पे किया है, और रिद्धि साहब की खास बात ये होती थी कि वो ये करवाते थे, शुरू में उन्होंने किया, फिर जो उनकी साथ टीम होती थी वो करती थी, और फिर वो उसको ये नहीं था कि आपके कैनुला वो बड़े वाले निकाल एक्सप्लोर करके फिर उन वेसल्स को आप रिपेयर मॉडल भी रिपेयर करें, ये भी रिपेयर करें और इसको उठा के बैठाएं। तो ये जो स्टार्जर टेक्निक है ये हमें बेसिकली जब हम लिवर ट्रांसप्लांट यूनिट में बहुत ज्यादा ये है ऑन है आजकल के टॉपिक, तो इससे रिलेटेड चीजें आप लोगों को बताऊँ। और ये प्रिंटर मैनुअल पढ़िएगा, आपने बताया ये ऐसे प्रिंटर मैनुअल नहीं, इसमें पूरा ऑर्गेनाइजेशन की जाती है कि आप राइट साइड पर है तो असेंडिंग कोलोन को, राइट साइड पे असेंडिंग कोलोन को आप उठाते हैं, जब ड्यूडेनम एक्सपोज हो जाता है वहां से आपको पोर्टल वेन और हेपेटिक आती होती है, और वहां कोई क्लैप नहीं लगाते, आप अपने एक थंब से उसको वहां से करते हो। तो ये प्रिंटर मैनुअल फास्ट टाइम जब आप रेनल ट्यूमर कर रहे हैं और वो लिवर को इन्वॉल्व फॉर्म है और आपसे किसी तरह से ब्लीडिंग कंट्रोल नहीं होती, तो मुझे नहीं पता आप लोग करते नहीं करते, लेकिन हम लोग की थोड़ी प्रैक्टिस थी जब हम ये प्रिंटर करते थे और वहां से ब्लीडिंग कंट्रोल हो जाती है। नेक्स्ट टाइम हम ये समझ लेते हैं कि रीनल एरिया से ब्लीड कर लिया जबकि वो लिवर से, तो स्पेशली राइट पैटिक को कंट्रोल करने के लिए ये प्रिंटर मैनुअल बहुत इंपॉर्टेंट। अगर कभी किसी को टाइम मिले या जो लोग एग्जाम देने जा रहे हैं तो ये छोटी छोटी चीजों की 5 मिनट में कर पढ़ने तो याद रही और एक स्टार्ट कर लेते हैं।
और आप भी सर आपसे पूछेंगे एग्जाम
ये है
coming slide है तो
and I have a privilege with my seniors के हमने कोई 40-50 में तो ये स्टार्टर्स किए हैं एनिमल में, और वो जाते थे भाई, मतलब पहले हम क्लैम लगाते थे, ऊपर जाते थे, इसके बाद चल पड़े
So Chevron or Mercedes-Benz lesion can be used in level 3 and level 4 as we discussed. And right atrial and bypass is necessary in venovenous bypass, cardiopulmonary bypass, or hypothermic circulatory arrest. The risk of morbidity can be substantial for thrombi extending above the diaphragm, and mortality rates associated with radical nephrectomy and IVC thrombectomy as high as 5 to 10% has been reported. Patient selection is critical as many patients, especially those with metastatic disease, will have a limited life expectancy. However, surgery can impart a significant palliative benefit by preventing pulmonary embolism and minimizing disability. Data regarding robot-assisted laparoscopic nephrectomy and IVC thrombectomy are emerging from a few centers around the world. Early data indicates that select patients with level 1 through 3 thrombi can undergo safe robotic surgery, although oncological outcomes remain preliminary and more demonstrated. So EUA guidelines recommendations are remove the renal tumor and thrombus in case of venous involvement in non-metastatic disease, strengthening are strong, and in case of metastatic disease, discuss surgery with the context of multidisciplinary. Thank you.